about details, you can ask, but I'm gonna try to explain it in a simple and short way as possible. So if you look at the agenda of my presentation, first I'm just gonna briefly define enteral nutrition. I'm sure you know what it is, but and then I'm just going to explain the main types of tube feeds, how dietitians determine when it's appropriate to start tube feeds. The fourth section is going to be on how they determine nutrient needs and how that translates into which formulas are selected. And then I'm going to kind of walk through the most common disease states that we have to look at, and just kind of explain kind of the thought process on what we have to think about in those disease states when we're choosing a formula. And I think I mislabeled the next one. It says when it's appropriate to stop. I think I was originally going to be talking about like when it's appropriate to stop and pause tube feeds, but mostly what I'm going to be talking about in that slide is a lot of the common reasons they are interrupted, and how that can be a problem, and then some suggestions that are given by evidence-based practice on how you could probably minimize that, and then of course the reasons why you would want to stop them. And then I won't spend a lot of time on it, but I do have a couple of slides just briefly talking about parental nutrition, like what it is, and at the end there's just a little diagram that shows like how to determine whether someone needs enteral nutrition versus parental nutrition. So, all right, so let's get started. So I do have notes with me, and that's mostly because I tend to go on tangents, so I need some guidance to keep it short, hopefully. But basically, when I say enteral nutrition, the enteral nutrition basically means just any nutrition that's going through the GI tract. So really, food that you're eating physically is technically enteral nutrition, but when I say enteral nutrition in this presentation, I'm mainly referring to tube feeds, and usually when other dietitians are mentioning enteral nutrition, they're talking about tube feeds, but technically, anything that goes through the GI tract is enteral nutrition. So, as you can see in the little diagram to the right, the formulas can be introduced in various points, but the point of enteral nutrition is that it's going through the gut at some point. Technically, oral supplements are a form of enteral nutrition as well. Things like that. Anyway, next. So the main types of tube feeds falls within 3 categories. There's a whole bunch of different kinds, but they mainly are going to fall under standard, specialty, and modular. And I will expound on those in upcoming slides. So first is the standard tube feeds. So sometimes another form or another way you might see a standard tube feed referred to is a polymeric tube feed, or a house formula. And that just means it's referring to a formula that's all intact, meaning that it's going to have everything that a patient's going to need. It's going to have carbohydrates, it's going to have fats, it's going to have proteins, and they're all going to be in their whole form. So really standard tube feeds are ideal for people who are able to digest foods normally, so they don't have any GI issues, and no specific metabolic issues or things like that. So let's see if there's anything else I need to mention. So basically standard formulas can be used for their full nutrition or just supplemental. So if someone's not getting all their nutrient needs just by eating, you can use it as a supplement. And some standard tube feeds will come with fiber in it as well. Sometimes that's a good option to help with the diarrhea, but sometimes that's not appropriate. And a lot of times you'll find that we don't really use that a lot in the ICU, and I will kind of explain that later. But some examples of some standard tube feeds is Nutrin, Fiber Source, Jevity, Osmolite.
I think it hung up. Sorry.
Oh, that's all right.
Because April just said she can't hear anything.
I know. Shall I wait?
Give me just a second.
Okay.
Let me pull it up on my phone. Oh, shoot, come on.
No, it just all of a sudden went out for her.
Yeah, now my phone's not even there. Okay, there we go.
I know, I hate this. I hate having to do things like that.
I tried to watch.
And my phone's getting old, so,
I tried to
lately
put it
it's
on
been
my
taking me
I tried to
off
put
of
it on my
the Wi-Fi
Plus
and
app,
stuff.
but it don't
Okay.
work like it
One
works
second,
on
let me make it on
the
speaker so you can hear.
And see, our mine recorded it
He recorded
for
it.
when he had.
Hold on.
Okay.
And then Bethany said,
Alright,
can we
yeah,
record you to
because
put it on the
usually
YouTube page, but if that would make you nervous,
So,
then we don't.
It doesn't matter. You can do that.
Does anybody have,
They're gonna miss
miss the first
all
part?
the standard tickets and stuff.
Yeah, they did. That's standard for you.
He gets something out of the
Anybody have space on their phone to video? I could go get my camera, I guess.
She looking at him like.
Sorry, I need to delay.
Oh, no, that's fine.
Can I do it on here?
But there was never an.
You wanna do a voice record?
Was there? Yeah,
I
there
was
was,
gonna
yeah,
do
there was.
video.
But there was never like an 11S.
Hey.
I got her on
We're having a
that.
party.
Adrian, I got you.
Yeah, oh, okay, you can go ahead, Mary.
You can go ahead, Mary.
Okay.
Mhm.
Yeah.
So we're just talking about standard tube feeds for those that, got caught off on the phone.
All right, so we're gonna go ahead and move into special, I'll pull this out. We're gonna go ahead and move into specialty tube feeds. So as the name implies, specialized tube feeds are meant for patients who have special nutrition needs. So there are two main categories to specialized formulas used in a clinical setting, and that's hydrolyzed formulas and disease-specific formulas. So hydrolyzed formulas are like standard formulas in that they're going to have all the macronutrients. So they're gonna have carbohydrates, they're gonna have fats, and they're gonna have proteins. However, what makes them different is the components are broken down into simpler forms so that they're easier to digest. They're gonna be, for example, the proteins are gonna be broken down into like di or tripeptides or free amino acids to make them easier to digest. And also, the carbohydrates are gonna be broken down into simpler forms, and the fats are gonna be in the form of like small amounts of oil or medium chain fatty acids. So the formulas can either be partially hydrolyzed or completely hydrolyzed. And so when you see formulas that are, it says on the bottle like peptide based or semi-elemental, that just means that it's partially hydrolyzed. So the macros are broken down, but they're not broken down all the way. And then if you see formulas that say elemental, that usually means that they're fully hydrolyzed. So they're broken down into the smallest
Smallest
components that they can
components,
be in. And
So that would be like our vitals.
Yeah.
That would be considered an elemental.
Which one?
The vitals.
Yeah.
Mhm.
Yeah, if it says elemental on it, that's what it means. So semi-elemental formulas are used for patients that have GI issues that might prevent them from digesting the standard formulas. Some of the GI issues that you might see that may indicate that they're not tolerating it well is if they have like nausea, vomiting, distension, or it could be diarrhea, but we'll kind of go into that later. Basically GI issues like malabsorption, short bowel syndrome, inflammatory bowel disease, things like that. So, but if a patient can't tolerate the semi-elemental, you'll have the option of using elemental. So if you still find that they're having problems, you can just go fully elemental and they might be able to digest that a little easier. So then we have the disease-specific formulas. So these are specialty formulas that are formulated to meet nutrient needs for conditions like diabetes, COPD, acute respiratory distress syndrome, for wound healing, chronic kidney disease, liver failure, all of that stuff. So each of these products have varying differences, and it's usually just in the amount of macronutrients that are included, and some of them are also hydrolyzed. And they're supposed to be formulated based specifically for those disease states. So, for example, there's some very high protein ones that are intended for wound healing, for example. However, though the intention of specialty tube feeds is great, and a lot of people are like really gung-ho for it, the literature on specialty tube feeds doesn't really support their use.
Interesting.
They found that in a lot of studies, when they're comparing patient outcomes as far as mortality or length of hospital stay, there really wasn't a lot of difference between standard tube feeds and specialty tube feeds. So a lot of times when they're using, well, actually I'll go into that later, but they also, a reason why you might not want to lean heavily on specialty tube feeds is because they're expensive for the hospital.
Okay.
And a lot of times insurance won't cover their use unless you can really prove that they need that. Especially if they're going to be on it long term, because it's really gonna be expensive. All right, so going on to modulars. So modulars are different from the other tube feeds we've mentioned in that they are incomplete forms of protein. So it's usually only one macronutrients in a modular. So one will be protein, one can be carbs, and one can be fat. Some hospitals use like combinations of modulars to meet nutrient needs. They'll just like adjust how many you use of each one to kind of tailor it. But you can also use modulars and add them to like standard formulas. Like if you have someone who needs wound healing, and they need a lot of protein, but you don't want to use a specialty formula to save money, you can use that standard tube feed and just add like the protein modulars to it to meet their needs.
Nice.
So really, the purpose of modulars is to be able to look case by case to patients and being able to tailor their nutrition using that without high cost. So, let's see if there's anything I need to say. Nope. And basically, and y'all already know this, modulars can come in liquid forms and powder forms. So they're trying to come out with more liquid forms because it's
Easier.
Yeah.
Then I put the water in.
Right, so-
Wait for it to dissolve.
I know. All right, so next,
That juice smell good though.
It does.
I'm gonna
It's like a.
I'm gonna try to introduce you to how dietitians calculate nutrient needs and what they're thinking of as far as how you're going to select formulas. So when we go into the different formulas later, you'll kind of know.
How you got there.
Yeah, exactly. So basically, all hospitalized patients are required to undergo an initial nutrition screening once they get here. It's going to be within 48 hours. So nutrition assessments are used to determine things like patient's height, patient's age, weight, their disease state or lack of disease state, comorbid conditions, how their GI tract is working. They assess their risk of aspiration and other things. So based on all those factors, the dietitians are going to use all of that information to calculate calories, protein, and fluid requirements. So those are the main three things that they're going to look at. The best way to calculate energy needs is something called indirect calorimetry. I don't know if y'all have heard of that, but it's basically just a device that, trying to think of a simple way to say it, is something you breathe into, and it basically calculates how much energy you burn.
You used.
It's
Yeah.
like the police, you know, the police.
Like a
stuff,
breathalyzer?
How you call it?
Yeah.
The breathalyzer?
Breathalyzer for
Yeah,
calories.
basically it
Energy
is a really, it's not the most accurate way, but it is one of the more accurate ways to determine how much energy you need to live.
To operate.
But a lot of times this isn't available for use, especially not for every patient. Yeah, it's very expensive. Like, I've probably only done it myself, well, I've only done it myself once.
Mhm.
We were supposed to do it, during my program, just so we could see what it's like,
Yeah.
and
Couldn't even
we
get it.
couldn't get, we couldn't even get approved for it, just because it takes a long time and it can be pricey.
Gotcha.
So most of the time, we have to rely on, weight-based equations. So, there's a lot of different weight-based equations, but, usually the most used one is something called Mifflin-St. Jeor, and I actually put a little example there in the slide where you can see, there's an equation for men and then there's an equation for women. And so you can see that the equation for men and women are a little different. But that is the Mifflin equation. So you use their weight in kilograms, their height in centimeters, and you use their age, and you just plug them into the equation, and it gives you an idea of their energy needs, basically to live. That's the energy they're gonna need to
So
do their,
minimal.
yeah, that's the minimal energy needs.
Okay.
So on top of that, we usually factor in their activity factor.
Mhm.
So based on whether they're sedentary or they're likely active or moderately active or highly active is gonna determine,
How much? they
how much we add to that. I think sedentary is like, 1 to 1.2, you're going to multiply that by what you get. That's sedentary. 1.3 to 1.4, I think, is lightly active, and so on and so forth. I think the highest that it goes is like 4, I think.
Mhm.
So that's how we
People
calculate,
like Kristen.
yeah.
4.
Mhm.
I wanna do it
So,
right now.
we have that equation, that's probably the
much as we're
most
eating.
used, and it has been shown to be the closest
Okay.
to indirect calorimetry, like, the numbers that you get are very close.
Okay.
So we use that one a lot. Some studies support the use of simple weight-based equations, and I provide an example there. You have 25 to 30 kcal per kilograms per day, so that is a very simplistic equation for the normal person.
Okay.
So depending on their disease state, that they have different simplistic equations for that. So you'll see when we go into the disease states, like for obesity, they're gonna have their own simplistic equation that you're gonna wanna use because, that one's not gonna be appropriate for them. All right, so moving on to protein requirements. So, like the energy, there are certain equations that we can take into account depending on their disease state. In the critical care setting, protein is the most important macronutrient for healing wounds and supporting immune function and maintaining lean body mass, especially if they're not going to be moving around a lot. They're at extreme risk of losing a lot of muscle. It really only takes a few days
Yeah.
for their muscle mass to go down
Yeah.
exponentially.
Oh, yeah.
A lot of times for the most critically ill patients, protein requirements are proportionally higher than their energy requirements. So they're not easily met by standard formulas. So in critical care, you're going to notice that if we're going to use specialty tube feeds or modulars, this is where you're going to find it. So mostly on the floor, if they're gonna be on tube feeds, a lot of times it's standard. But on ICU, this is where we're gonna
That's
be
why we have all that
mostly.
extra stuff on us.
Exactly. That's where you're gonna see most of those specialty things.
Gotcha.
So as far as energy needs, a standard simplistic equation we'll use here, just because they're going to need higher protein, is 1.2 to 2 grams per kilogram. Normally for an average person, it's usually just 0.8 to 1 grams per kilogram of body weight, which doesn't seem like a lot, but an average person with average amount of activity, that's going to meet their needs. But in the ICU, they're usually automatically going to need more. So 1.2 to 2.0 is the most commonly used. And my preceptor wanted me to add this little bit about assessing protein needs, and that is we got to do away with using serum protein markers to assess protein. A lot of doctors still like to use things like albumin and prealbumin transferrin CRP to assess protein, like whether they're meeting their needs or not, and that is not a validated form to assess that. And the reason why is because these are protein markers that they decline in the presence of inflammation, and a lot of disease states involve inflammation.
Yes.
And so that will interfere with the accuracy of those biomarkers.
Gotcha.
So even though they may be associated with nutrition risk, like
It may not be accurate.
exactly, they're not accepted as measures of total body protein or total muscle mass or malnutrition. So don't rely on those, especially if they're in a state where they have a lot of inflammation.
Yeah.
All right, so
Exactly.
So now we're gonna be I'm gonna try to quickly go through these, but we're gonna look at the most common disease states that we have to look at when we're deciding on tube feeds. So first is obesity. So when we see someone who's obese, we automatically think they're going to have to be on a hypocaloric diet. This isn't always the case. Sometimes if they're on CRT or if they have like an open abdomen, we might have to give them more than this equation will give them. But usually when we see an obese patient, it's going to be 11 to 14 kcals per kilogram per day. Or a simplistic equation, you can also use ideal body weight with 22 to 25 kcals. And if you're curious what ideal body weight is, I put our calculations for ideal body weight underneath that. After the high protein, you can see that there is a different formula for men and women. And then we also have, I didn't include it, but there is also a way to calculate recommended body weight, and that's using BMI. I didn't put it, but usually recommended is based on a 22 BMI for women and 23 BMI for men, but we don't really use that very much just because there are issues with BMI. So we don't really use that very much.
Not
So,
fair. Not fair.
yeah. So, and then obesity, so they're going to have low calorie and then high protein, mainly to help them maintain their muscle mass and also help them stay fuller longer. So, so when we look at formulas, we're looking at low calorie, high protein. And so some of the formulas that we will consider for them are formulas like Peptamen BHP or Vital High Protein. All right, so for diabetes, there's really, we really have to weigh standard formulas versus carb-controlled formulas. Even though the evidence doesn't really support like a benefit of carb control over standard, a lot of hospitals just automatically go towards the carb control so they don't have to worry about their glucose.
Okay.
But if they're on a really good insulin regimen, for example, you can, a lot of times they can use standard formulas as long as you're, carb control is the specialty, so it usually has like high protein and like low carbs in it. But like I said, the evidence really doesn't show that there's a difference in mortality or length of stay compared to the other one. Yeah, so it's really just case by case basis, and you use clinical judgment. You can start out using a standard tube feed, but if you find that you really can't manage their blood sugar, then you can move to the carb controlled one and see if that works for them better. So Glucerna is usually the main one for all the hospitals. All right, so for renal disease, there's two main things you have to take in consideration when you're deciding a tube feed for them, and that's their renal function, like how well their kidneys are working, and whether they're on renal replacement therapy. And then again, like diabetes, based on those things is going to determine whether a standard formula, whether you can use that, or whether you need to use a specialized formula, which is usually going to be low protein, calorically dense, low potassium, magnesium, and low phosphorus. So like for CRRT, for example, or well, let me just say, if they're not on CRRT, A lot of times you want to kind of do lower protein because you want to control their phosphorus and control their BUN. But if they're on CRT, they're losing a lot of fluid and therefore they're losing a lot of protein. So you're actually going to want to give them a lot of protein to kind of make up for that. Usually they're going to need 2.0 to 2.5 grams of protein per kilogram. So in those cases where you're going to need low protein, so someone who's not on CRT, and you see that their potassium is like out of whack and their phosphorus is out of whack, you might want to opt for a renal formula. And some examples of renal formulas are Novasource or Nepro. If they need high protein, you might have to opt for a high protein formula, which you'll see some examples of those. And you'll actually see some examples of those next when we talk about trauma.
You heard that?
Remember?
Impact.
Oh, impact. I have.
You have? I've never heard of that. Even when I worked in sticky, like we
Okay, yeah.
vital for the most
So
part.
trauma is gonna be one of those disease states where they're going to need a whole lot of protein, and depending on the level of trauma they're at. So usually the next step for trauma, you're gonna need 1.2 to up to 2.9, so a lot of protein, grams per kilogram per day. And if they're open abdomen, they're gonna need even more than that. So it's 1.2 to 2.0 plus an additional 15 to 30 grams per milliliter of output. So lots of it. And some formula considerations that are really high protein is impact peptide, and the vital formulas. Traumatic brain injury, so that's still trauma, so technically I could have put it under the same heading, but again, increased protein, so 1.5 to 2.5 grams per kilogram. And then again, some formula considerations for that high protein is impact peptide and vital high protein. So usually you want to use these if you, for instance, if you're using a standard formula and you try to bump it up to meet their protein needs, they're going to have way too many calories, which can cause complications. So this is why you would want to either opt for a high protein one, because it usually has lower calories in comparison to the protein, or you can use the standard with a lot of modulars, so which I have seen before. And then post-operative SICU patients are one of the exceptions when it comes to specialty formulas. This is the one case where the literature actually supports using a specialized formula for them, and that's using an immune modulating formula. And that's because it has showed that it cuts down on the amount of infection rates when used for those patients.
Interesting.
So examples of immune modulating formulas is impact and impact peptide.
And that's the only one, but we don't even
We don't
have
have that,
that.
yeah.
So
I had a
Yeah,
patient
Lana.
using that Cake Farms when I remember it was
Cake
some,
farms.
because we were
They
like,
bring
who
it
never,
in.
yeah, it was like, yeah, it's like a specialty.
yeah, so for allergies, there's
Yeah.
special formulas for that as well.
Yeah.
Kate
yeah.
Farms is one of the only vegan
Okay.
food feeds.
Yes.
So if you have patients that are
Nice.
extremely like lactose intolerant,
Mhm.
you can use Kate Farms. I'm at Piedmont right now. They actually have Kate Farms as part of their formulary.
Oh, wow.
I think Grady is starting to use it more.
Is
I
it-
think I've
is
only
it a
seen it once,
significant-
and someone brought it from home here.
More,
Yes.
is it more expensive, I'm assuming?
It
Oh,
is,
yeah,
because
it's
it's
vegan.
Yeah.
and it's really the only one you can find like that.
Yeah, that patient
yeah.
that was here, the daughter was an anesthesiologist and
Was
she
bringing them in,
was
yeah.
bringing it in.
Wow.
So, but there are some
Yeah,
other
I've seen it
options if they
before.
have allergies like lactose intolerance. Another option, if you don't have access to Kate Farms, is using hydrolyzed formulas because those proteins are already broken down. So a lot of times, those will work for them, but there are special cases where they won't. And in those cases, you have Kate Farms, and then there's also Complete, but a lot of places don't use Complete because it's a blenderized formula, and those can be kind of funky. I'm not really going to go into it only because it is used very rarely. But if you're interested in blenderized proteins, you can look it up. All right, so starting tube feed. So when considering whether a tube feeding is appropriate and when to start, there are a couple things that dietitians have to consider. First, you have to determine if the patient can eat on their own and if their GI is functioning properly. If there is no issues with the GI tract, but the patient is unable to eat an oral diet, like when speech says they're not able to swallow. Or in the case where oral intake doesn't meet their needs. So in this case, if they're meeting less than 50% of their nutrient needs that we calculate for them within 5 to 7 days, this is when you're going to consider a tube feeding. So if the issue is inadequate oral intake, so if it's just that they're not eating enough, but they're still
Able to take in.
able to take in something, tube feeds can be supplemental for them, like if they're still eating just not enough, or it can be full if, especially if they're malnourished, like severely malnourished, then you can give them like more. So depending on the severity of their malnutrition is going to determine how much they're going to need. So when considering when to begin tube feeds, a dietitian is going to calculate what is called a Nutrix score. So you'll see the little box to the right, that's a Nutrix score form. So basically the dietitian will go through there and like score the patient, and that's going to determine their nutrition risk. So patients who are at low nutrition risk, who have normal baseline nutrition status, meaning that they were eating normally at home, and they have low disease severity, but they're just not taking in food right now, like it's an acute illness, you might not have to start tube feeds right away. They can usually go like a week without it if they have a good nutrition baseline and if they're not like really sick. So sometimes they'll hold off on tube feeds for that because you don't want to be causing unnecessary complications if they don't need it. So patients who are at high nutrition risk or severely malnourished or have acute respiratory distress syndrome or things like that, those are appropriate candidates within the first week of them being there. So, and then of course in the ICU you have to take into account that things can change at the drop of a hat. So even though a dietitian will look at a patient and be like, oh, I think they'll be okay for a week, or I think we need to start tube feeds, things can change day to day, so it's really important for dietitians to regularly assess the patients and determine if things need to change. All right, so then we'll go into interruptions and discontinuations. So when you're talking about when to stop, the ideal time to stop tube feed is when the patient is able to take in food orally. So that's the ideal time to stop. However, there are factors that can happen that frequently interrupt and stop tube feeds before this point. So unfortunately, critically ill patients who receive tube feeds, a lot of times they're not going to meet their nutrition needs that we calculate for them. According to studies, patients on an average basis only get like 59% of their energy needs and 60% of their protein needs. So that's average, so it's not that good. Interruptions, the common length of time that critically ill patients go without tube feeds is about 5 hours per day when you add up all the interruptions throughout the day. So that's about 5 hours that they're not getting what they need, and which can be really bad for patients who are severely malnourished. So there's a lot of reasons that it can be interrupted, and I'm sure you know them, but the most common ones that are cited in literature are they can be interrupted for operations and procedures. They can be interrupted for having to lower the bed for
Bed care.
Repositioning
Yeah.
and cleaning.
Baths.
exactly. And then of course the tube feeds can become clogged or dislodged, so they're going to have to be stopped for that. And sometimes it takes
Dropping
time
into
to
tube.
put them back in and check that they're in the right place. And then of course they can be interrupted if for intolerance reasons, like a lot of times they're interrupted for gastric residuals or
Infections.
vomiting and things like
Forward.
that.
So when
No
you,
nutrition for
as
a
a
week.
dietitian, when you're creating the nutritional needs, do you account for any of that?
A lot of times, yes. So when they're calculating needs for critically ill patients, that is another reason why they will give them a lot of protein and sometimes a lot of calories depending on the patient to kind of account for that. But a lot of times it's still not really enough. So it's really the dietitians and the rest of the care team really kind of have to work together to both determine appropriate needs based on how often they have to be interrupted. Like for instance, at Piedmont, I'm working in a cardiac ICU right now, and a lot of times those doctors don't like to do nutrition because they're always waiting on a procedure. But you know how procedures go, even if you schedule it,
Delayed.
and the dietitian's like, oh, I'm gonna account for that. Sometimes schedules don't go as planned and they get pushed off, so they end up going longer than the dietitian accounts for because of that changed schedule. So those are things you have to
So, I have
keep
a
in
question.
mind.
In a case like that, would TPN be more better situated since it's not interrupted and things of that?
Well, the thing about TPN is there's a couple of reasons why you want to be cautious about TPN. One is that it can introduce a form of like a site of infection.
Right.
Because
So-
you have to have either PEG or
Yeah,
central line,
right.
they don't
And
like
it
that.
Just a
creates an
fungal.
environment,
The phone.
Yeah,
They're
for
very-
breathing.
for
And
breathing.
also, if the patient's digestive system is able to
You don't wanna disrupt
to be
that.
used, you want to use it because, like anything, if you don't use it, you lose it.
Yeah,
Yeah.
And the longer that they don't use it, the more it can cause issues with their GI tract
It
because
is.
it's not being
It's not
used.
Gotcha.
So really, dietitians really like to use the GI tract when possible because they show that they really do better than patients who are on TPN, especially long term.
So would you maybe choose bolus feedings versus
Oh, yeah.
continuous feedings?
They have that, and they also have things like trickle feeds where you can just kind of do like little trickles at a time, so at least it's getting used
Yeah.
and at least it's doing something.
Cause I was thinking of like
Yeah.
residual, if it's high, then you wouldn't continue to wanna pump them with something they're not digesting.
And there are guidelines as far as gastric residual volumes. I think,
Cut by half, stop for an hour.
yeah, a lot of times they're
Yeah.
finding that nurses are stopping gradual residual volumes like around like 200 or 250, but really
It
they're
could be
saying,
more than that,
they're really saying that
300, right?
it's
Four.
500.
It's five, I don't know about
Yeah,
4 or 5.
500. If it's a,
For it to sit in your stomach.
well, the thing is there's a lot of factors that go into that. You have to factor in how soon they were getting that tube feed, and how many, like the
The
natural
weight.
secretions that are gonna be in your stomach, and also their positioning and things like that.
Yeah.
The research really says that if it's below 500 and they don't have any other symptoms of intolerance,
Like, no,
that there's really no research that says you have to stop it. If they're over 500, then yeah, you might want to reassess. And then there are steps that you can take, like I think I wrote some down just in case y'all are interested about it. They say some of the options you can do is you can assess for GRV every 4 hours and withhold only for greater than 500, or you can also assess for intolerance using physical assessment, evaluation of glycemic control, minimizing sedation, and or considering a promobility agent. So like or prokinetic agents like erythromycin or I never know how to say those, metoclopramide.
Regular.
Oh, regular, that's what I was thinking
Yeah.
about.
Yeah.
I was thinking about
Yeah,
starting with
there's
regular.
there's
That's the first
other
thing I thought
names
about.
for it, yeah. And you can consider those if you notice that they're having like a lot of episodes where they're over 250, you can use those other means to change it. But if you find that that's not helping, then you just need to assess. Again, it's based off of clinical judgment and how the patient's acting and things like that, so. And you can also consider post-pyloric tube feed access, so if you move it farther down in the GI tract, that's also gonna decrease their aspiration risks and things like that. So there's a lot of things that you can use, but like I said, they're really, really pushing now not to stop the tube feeds based on GRVs unless there's other symptoms going on.
Right.
So we already talked about some of the ways that you can decrease the amount of times nutrition is interrupted is taking into account the GRVs, but also trying